I'm Eric Lamar, and I'm going to talk to you about ENT for the general surgeon. And in particular, I'm going to focus on evaluation of a neck mass in the adult, because that seems to be one of the areas that I get most interplay from general surgeons. And so just to introduce myself, I'm a head and neck oncologic surgeon in reconstruction at the Cleveland Clinic. So I have no financial conflicts to disclose. And so let's start with the definition. A neck mass is essentially an abnormal lesion, can be congenital or acquired, that is typically visible, can be palpable, or seen on imaging study incidentally. The mass is anywhere below the mandible, above the collarbone, and deep to the skin, although it may at times involve the overlying skin secondarily. So the incidence is rather common in all age groups. It's hard to find out exactly how much or how much we see it in the outpatient world, but in a old review that looked at approximately 19 years of 3 metropolitan hospitals, it accounted for somewhere in the order of over 7,000 admissions. So a fairly common finding. And in order to kind of navigate through the differential diagnoses, it really requires a detailed understanding of the anatomy, which I will go through. Additionally, it requires an orderly progression of tests that are aimed at identification of potential primary sites of cancer. And we will also go through an algorithm to delineate that. So let's look at the differential diagnoses. Now, this is not an exhaustive look. There's a number of other pathologies. These are the most common ones. And so you can see many of these are managed quite differently. So it's important how you approach the neck mass in order to get a diagnosis and then embark on the appropriate treatment modalities. So the ones that I'll focus on quite a bit is the head and neck squamous cell carcinoma. Those tend to be cancers that originate from the upper aerodigestive tract and will metastasize to lymph nodes in the neck. There's also an entity where the primary cancer is not identified within the upper aerodigestive tract, but nevertheless, it has metastatic disease within the lymph nodes themselves. Another phenomenon is lymphoma. You can have lymphoma that predominantly affects the neck, and so it's important to be cognizant of that in the differential. Other are neurogenic neoplasms or paragangliomas, carotid body tumors, which we'll talk about a little bit later on. Another consideration is salivary gland malignancy, thyroid neoplasms, which have been addressed elsewhere, as well as lipoma. And so those are, in general, the ones that we tend to see most of. There's also the possibility of this being congenital neck mass, and I'll look at how to delineate what age group is highest risk for each of these. These neck masses that are congenital include thyroglossal duct cysts, branchial cleft cysts, dermoid cysts, teratomas, lymphangiomas, and hemangiomas. And finally is inflammatory lymphadenitis and granulomatous disease and sialadenitis, or swelling of the submandibular glands that could be either from an infection or secondary to a submandibular or parotid stone. So sometimes you can get stones that block the exit of saliva and as a result get some swelling of the associated salivary gland. So as in all diagnoses, it begins with a history and physical examination. So age is really key because I think it starts to narrow down ultimately what likelihood of each respective diagnosis is. And so in the pediatric world, as you can see in the chart here, we tend to have more inflammatory, more congenital as well, and a small fraction tend to be neoplastic. As you get to the older or young adults, neoplasms start to go up, and inflammatory disease tends to go down, whereas congenital stays about the same. And finally, as you get to an older adult, a neoplasm really starts to go up. And so it really should be the focus or primary consideration of a neck mass in a patient that's over 40-year-old. And I'll reinforce that throughout this talk. So one of the driving forces behind this talk, I think, is the increased rate of a malignancy that we've been seeing that's called HPV-related oropharyngeal squamous cell carcinoma. So the incidence of this has really reached epidemic portions, and so in the last 10 to 20 years, it has more than doubled. And it's expected by the year 2020 that the rate of HPV positive squamous cell carcinoma of the oropharynx is rising so rapidly that it'll exceed that of the more commonly known uterine cervical cancer. So this is really a phenomenon that has really started to affect a whole different demographic of patients, as well as we've seen an increase of an incidence in comparison to other cancers of the upper aerodigestive tract, which we've seen a decrease in incidence. And that's what this figure shows here. So HPV-related squamous cell carcinoma of the oropharynx, and just to, we'll mention this again later on, but oropharynx tends to include tonsillar tissue or base of tongue, which is also tonsillar tissue. So in that area, you have something that we commonly refer to as Waldeyer's ring, which is essentially a ring of tonsillar tissue. And what we've found in the last 2 decades is that HPV can infect this tissue and ultimately lead to malignancies. And the time of infection to the time of detection of malignancy tends to be anywhere on the order of 20 years or so. But nevertheless, it has become a very significant etiology for these malignancies. And so as this figure shows, this line here shows the decrease in cervical cancers. And what we've seen during the same time interval is an increase in oropharyngeal cancers. And again, it's projected that after 2020, it's going to actually exceed the incidence of cervical cancers. The blue lines are looking at men tend to be more disproportionately diagnosed with this than women. And then if you project that out somewhere like 20 years or so, again, you see the increase in oropharyngeal cancer that's been projected and relative decline in cervical cancer. As I briefly alluded to earlier, we're seeing a rise in oropharyngeal cancer in relation to other upper aerodigestive tract malignancies, and these tend to be caused more by smoking and heavy alcohol use. And so as campaign has been more effective in terms of increasing awareness of tobacco with malignancies, there are fewer smokers, and as a result, there tends to be less malignancies associated with that risk factor. But on the other hand, we're seeing an increase in oropharyngeal cancer. And then this is also projected out 20 years. Again, you'll see the sharp rise in oropharyngeal cancer in relation to other malignancies of the upper digestive tract that tend to be more smoking and alcohol related. And as I mentioned earlier, this is affecting a whole different patient population. They tend to more likely to be Caucasian, middle-aged, moderate to upper income. And so this is quite in contrast to many of the other malignancies that we see in the head and neck area, particularly squamous cell carcinoma that's non-HPV related. This is a similar idea, just depicted differently. And so a study looks at both oral cavity as well as oropharyngeal cancer. And what we've seen is OPC here is, again, an increase, whereas other non-HPV related malignancies tend to be going down. One thing that we've also noted is that patients with oropharyngeal cancers tend to be, that are HPV positive, tend to respond better to conventional treatments. And so the patients are living longer. And that's what this depicts here on how the cause-specific survival over time for This is for oral cavity, and again, oral pharyngeal cancer. We're seeing more of it, but patients are also living longer as well. So it does portend a more favorable prognosis. So the bottom line is adult neck masses. A neck mass in an adult is considered malignant until proven otherwise, and I cannot reinforce this enough. This is really a key point. Because ultimately, timely diagnosis is paramount, because a delay in diagnosis directly affects tumor stage, and as a result of that, may adversely affect prognosis. So it's really key to act on these fairly quickly. So delays in referral to secondary care from head and neck squamous cell carcinoma is a problem worldwide, and part of it is due to the relative rarity of the tumor. These cancers, and as a group, head and neck cancers occupy approximately, are the sixth most common malignancy. However, many practitioners will not see it in their professional lifetime. And so there's no screening test necessarily in order to identify, unlike things like cervical cancer, pap smears, and so forth, that help to pick them up in an earlier stage. So in general, there's a mean delay of, some studies have shown 2 to even 4 months in referral to secondary care, which all impacts tumor staging and timely treatment. And what are the reasons for delay? I think one of the big ones that I see in my field is that the lymph nodes themselves are often cystic. And so there are other pathologies that I mentioned earlier that tends to confound the clinical situation. So cystic node is also seen in branchial cleft cysts. And so that's why it's imperative for patients that are 40 years old and above that you really had the mindset going in to see the patient that it's a malignancy until proven otherwise. Also, a reason for delay is the patients are often younger, and they, as I mentioned earlier, they lack the conventional risk factors that we associate with cancers of the head and neck, and that is namely tobacco and alcohol exposure. So further along the physical history and physical examination is the time to presentation. And so it's key to really identify how long the mass has been there. Obviously, the longer it's been, then the more concerning it is for a malignancy. Shorter time intervals and associated symptoms that may be reflective of an upper respiratory infection, you can treat these as lymph nodes that require antibiotics, but in general, as I'll allude to later on in our algorithm, you really want to tease out what the time to presentation is and have a high index of suspicion for a malignancy. You also want to look at risk factors, tobacco, alcohol, also a history of radiation to the head and neck, and really want to tease out associated symptoms. So any issues with their throat, oftentimes malignancies can have referred otalgia or ear pain. Have they had any oral ulcers, changes in their voice, changes in their breathing, stridor, hearing loss, issues with respect to their nose, epistaxis or nasal obstruction, a history of head and neck cancer, or even a history of skin cancers. These are all obviously very important to elicit. So what's really key, I think, in navigating through the differential diagnosis is a knowledge of the anatomy, as well as the lymphatic drainage site of the head and neck. And so this figure here depicts how we communicate as head and neck surgeons in terms of the neck anatomy. So if you look this, this is really key to figure out where the lymphatic drainage site will be in each respective area. So we'll go over this. So level 1A is demarcated by the anterior belly of the digastric bilaterally and the hyoid bone. Level 1B is the anterior belly of the digastric and posterior belly of the digastric, and tends to be where the submandibular gland is. Level 2 is demarcated by the hyoid bone inferiorly and the skull base superiorly. cut away here is the sternocleidomastoid, which serves as the posterior extent of level 2. The thing that separates level 2A from 2B is the spinal accessory nerve back here. Level 3 it occupies a position between the hyoid bone and the cricoid cartilage, and again is anterior to the posterior aspect of the sternocleidomastoid and tends to be posterior or lateral to the strap musculature. So that's the sternohyoid, sternothyroid muscle, and the omohyoid. Level 4 is inferior to the cricoid cartilage and superior to the clavicle, and again, anterior to the posterior aspect of the sternocleidomastoid and posterior to the strap musculature. Level 5 is demarcated by the sternocleidomastoid anteriorly and the trapezius posteriorly. And level A and B of 5 is typically demarcated by the omohyoid muscle. So again, this serves as real importance in terms of identifying where a potential primary malignancy is, as you can see in this figure here. So starting here, submandibular triangle, or level 1B, tends to be more of malignancies emanating from the tongue or the floor of mouth, gums, mucosa of the cheek. Underneath the jawbone, or level 1A, is rarely involved with cancer, but can be involved from lip cancers. This area here, level 2, tends to be the more posterior aspect of it, tends to be more of the nasopharynx. That's all the way in the back of the nose. And this area here tends to be a majority of the upper aerodigestive tract malignancies. That's the larynx, the pharynx, the oral cavity, oropharynx, all have the potential of spreading to that location. Anything posterior to the sternocleidomastoid tends to be drainage sites of the nasopharynx, the scalp, ear, or the skull base even. And then down in supraclavicular fossa is where we worry about Virchow's nodes or drainage sites of malignancies from other parts of the body, such as the esophagus. You can even get it from the thyroid, or rarely from a primary below the clavicle itself. So again, to reiterate, level 1 basin tends to be lip. You can get some oral cavity and skin of the face. Level 2, again, that's from the skull base to the hyoid bone, just anterior to the posterior aspect of the sternocleidomastoid. You have the oral cavity, oropharynx, the nasopharynx, the hypopharynx, and larynx. And that similarly is the situation for level 3, although you can add thyroid to that as well too. And then level 4 tends to also have those malignancies, oropharynx, hypopharynx, larynx, the cervical esophagus, and the thyroid. And as I mentioned, level 5 can be the posterior scalp, the ear, even the GI tract, breast, genital, urinal, nasopharyngeal, and thyroid. One thing I didn't mention beforehand are parotid nodes. So the parotid tissue is just in front of the ear. You can have drainage sites from the scalp, nose, cheek, or ear. So it's important to be cognizant of that on your history and physical examination. So let's talk more about your physical examination. So whenever I have a neck mass, I do a full head and neck examination. That is imperative to evaluate all mucosal surfaces. So you want to look at the oral cavity in great detail. That's the buccal mucosa, the tongue, underneath the tongue, floor of mouth, the oral vestibule. Also want to look at the soft palate, the oropharynx, the tonsillar tissue, the posterior pharynx. You want to also look at the upper aerodigestive tract, and that's why the flexible laryngoscopy is key. It's hard to evaluate these without it. And so that area, we look at the base of tongue here. And again, that forms the Waldeier's ring that I mentioned before. And this shows a flexible laryngoscopy here. So the view that you can get of that. So this is the epiglottis, the base of tongue here. And again, you see the vocal cords here. This is the hypopharynx, that's the entrance of the esophagus. And so it's really key to evaluate all of these mucosal surfaces in someone with a neck mass, because you want to rule out the possibility of there being a primary malignancy in the upper digestive tract that has spread to the lymph nodes in the neck. In addition to that, you want to palpate the thyroid as well as the submandibular glands and parotid glands, and really identify if there's any history or active skin cancers of the face or scalp, because all of these can manifest themselves in terms of a neck mass. Then the next step is diagnostic imaging. And so we'll talk a little bit more about this later, but just introduce the general options that are most common. Ultrasound tends to be used more for pediatric neck masses, thyroid masses, and it's very good at differentiating solid versus cystic. In general, the CT scan tends to be the most common diagnostic imaging, and it's really the workhorse for adult neck masses. I think it gives good spatial resolution of the surrounding structures and is really key in working up a neck mass. The MRI is also very good. It tends to be better for skull-based pathology, salivary gland neoplasms, and neurogenic neoplasms. And so this depicts a deep lobe parotid tumor. Right here is the parotid gland, and you see the tumor itself emanating from the deep lobe of it. So it's really good for that pathology as well. PET scans, once you get a diagnosis of a malignancy, are key for staging head and neck neoplasms, as well as if you have a neck node that you've diagnosed squamous cell carcinoma with, identifying an unknown primary is really useful to get a PET scan to help with that. So let's look at the overall workup of a neck mass in terms of how to proceed from the standpoint of algorithm and really evaluate it well. So this was a guideline that was put out in 2017, and we'll go through it step by step. But the intent is to reduce delays in the diagnosis of head and neck squamous cell carcinoma, and it provides overall 10 recommendations. And so this is the algorithm that they provide, and it's a little busy, but think of it in terms of, on one column really is antibiotic therapy, and in the other column is what to do when you highly suspect malignancy. But we'll go through this, and each step of the way are key action statements that are based on evidence-based guidelines. So we begin with an adult with a neck mass, and so the first thing you want to identify is signs and symptoms of a bacterial infections. So it's you really want to avoid antibiotic therapy for patients with a neck mass unless there are signs and symptoms of a bacterial infection. So this could include an upper respiratory infection or something that is of brief duration. I noticed a neck mass that's been present for a week and a half, 2 weeks, and it was accompanied by a sore throat or ear pain. And I think that's a reasonable way to start with antibiotics. But for something that has been present for a longer period, so standalone suspicious history, you get to kind of shifted off to this column here. So one or more suspicious findings of increased risk of malignancy. And so you really want to tease this out in the history. So you want to identify those that are at risk. Has the mass been present for over 2 weeks without significant fluctuation? Or many patients will come and they really don't know how long it's been there. They noticed it when shaving or after looking at themselves in the mirror, and they don't know how long it's been there for. So that you want to kind of really have a high suspicion for a malignancy. So as we go down this algorithm, you really want to tease out from the physical examination, as well as signs and symptoms, findings that are more concerning for malignancy. In particular is the lymph node or mass fixed to the adjacent structures. If you're having a hard time moving the mass itself from the muscle or from surrounding structures, it should alert you that there's a higher possibility of there being malignancy. Also, you want to focus on the size. Is it greater than 1.5 centimeters? And or ulceration of the overlying skin could alert you that perhaps you're dealing with a malignancy. So another key component, I think, is once you've identified patients with these findings, is really to educate them that you're concerned that there may be a risk of malignancy. And that'll really maintain the transparency as to why you're going to proceed with the following test, and alert them to your concern that perhaps you're dealing with a malignancy that's coming from elsewhere, or perhaps that is something that needs to be investigated further. So these are suspicious findings that really should alert you that there's a malignancy, and we mentioned some of this earlier. So typically patients are over 40 years old, although I've seen malignancies present as early as 32 and even younger. What's the tobacco and alcohol use? Is there associated sore throat, issues with swallowing, ear pain, oral or pharyngeal ulcer, changes in voice, as I mentioned earlier, unexplained weight loss, tonsillar asymmetry, skin lesions on the face, neck, or scalp? And then you want to move down and follow up for patients that are not at risk. And so this addresses the previous, the second column to the right. Even though it may sound like it's an infection, you still want to maintain some index of suspicion. And so it's imperative to create a follow-up for the patients. So for patients with a neck mass who are not at increased risk, clinicians should advise patients of criteria that would not only trigger additional evaluation, but also document a plan for follow-up. So this is really key. And we had gone beforehand the importance of patient education, particularly when you feel that they are at increased risk of malignancy. And that'll help to explain any recommended diagnostic test moving forward. And overall, you want to do a targeted physical examination, as we went over beforehand. For those that you're not able to obtain a diagnosis quite up front, and you think is not necessarily squamous cell carcinoma, the clinician should obtain other ancillary tests based on the history and physical examination. So this point within the guidelines was intentionally vague and are left to the discretion of the clinician themselves. So that's the area here that I'm referring to. So again, to remind us, this is where we suspect that there's a malignancy. This is where it's thought to be more infectious. Here you start antibiotic therapy. Do we have resolution? No. And if no resolution, then you make sure you document or discuss with the patient that we have a plan, and that gets directed over here. So perhaps this is more of a malignancy then. If there is resolution, then that's the completion of management. Down here is are one or more suspicious findings of increased risk of malignancy. If yes, then begin to educate the patient, as we discussed earlier. If no, then you can perform ancillary test. And this was what I had mentioned in the previous slide. And so this includes, if you're at, it could also be risk of having something like a lymphoma. And so would prompt additional either a FNA or laboratory work, or even a CAT scan of the chest if there's other symptoms associated with that as well too. Going back to malignancy of the upper digestive tract, again, you want to do a targeted history and physical. And then that brings us to our next step, which is CAT scan of the neck or some type of imaging along with fine needle aspirate. So the imaging of choice, as I mentioned earlier, the workhorse tends to be the CAT scan. That is typically the first test that we order. I'll discuss briefly some other imaging that or diagnoses that where MRI may be a little bit more favorable, but you can't go wrong with ordering a CAT scan up front, because I think it gives you a good evaluation of the neck itself and any other pathologies that may be incidental. So a CT or MRI, based on specific clinical situation. Ultrasound, if you suspect that there's thyroid-related malignancies. And once you've confirmed malignancy, is the PET scan, as we discussed earlier. So let's look a little bit closer at CT versus MR. So American ACR panel on neurologic imaging in 2018 on adenopathy suggested that in a non-pulsatile mass, that CT with contrast is the preferred initial imaging modality. MRI tends to have improved soft tissue with intrinsic contrast. I tend to reserve these for skull-based pathology as well as salivary gland pathology. But certainly you can't go wrong with the CT neck to begin with. There's really no current literature comparing the efficacy of CT, CTA, MRI, or MRA for a pulsatile neck mass. And I'll distinguish that in subsequent slides. How about for imaging of the parotid gland? CT tends to better delineate bony details and stones or sialoliths. The MR is a preferred evaluation for parotid glands, as it provides information of the full extent of mass. Also identifies the deep lobe of the parotid, as I showed earlier, as well as any perineural spread. That's why I tend to use it more in the skull base. So ultrasound of the neck, it's probably has increased utility, certainly more experience in the thyroid, but its use in the US is lagging behind Europe and Southeast Asia. It's in general useful in differentiating cystic versus solid pathologies. Also, thyroid pathology and salivary gland pathology. But it does have some limitations, particularly in soft tissue invasion and approximation of masses to bone. How about the FNA? So as we go further down in the algorithm, FNA is really key. And the recommendation is more of a fine needle aspiration instead of an open biopsy. And what is the accuracy of FNA? FNA tends to be fairly accurate, is 73 to 98%. Core needle biopsy is even more accurate, 83 to 100%. And so I think the key after you've obtained imaging, or even when you see a patient in your office and you feel a palpable lymph node, is fine needle aspirate, in contrast to proceeding directly to an open biopsy. Now, for squamous cell carcinoma, it, for the most part, tends to be diagnostic. However, for lymphomas, fine needle aspirate is not the final step. Oftentimes, it can alert you that you may have some lymphoproliferative disorder going on, and that could then direct you to take further steps, such as an open biopsy or even a core biopsy as well, too. But certainly a fine needle aspirate is key to help tease out what you're dealing with. So I think historically there was a lot of concern about tumor seeding after FNA and core. This was the hypothesis that you put a needle in, and then right along the tract you can end up seeding tumor cells within it. But a very comprehensive systematic review showed that this was not the case, and crude estimates suggest that this is very, very, very rare for both FNA and core needle biopsies, respectively. And so that's why I think it serves as a very first step in diagnoses of neck mass. So the challenge becomes that if you don't obtain a diagnosis, what do you do next? And I think particularly for squamous cell carcinoma, this tends to be quite a challenge. If the mass is cystic, continue evaluation until a diagnosis is obtained, and do not assume that it is not malignant. That's really a key point, I think, in this. If your fine needle aspirate is either equivocal or negative, and you have a cystic lymph node, still maintain an index of suspicion that this is malignant. And I'll explain that moving forward. If this is, um, obviously, if this is a malignancy, then manage the diagnosis. And then subsequent to this, ancillary tests will be based on history and physical examination, and we'll talk a little bit further about what a panendoscopy and open biopsy is. So let's talk about cystic neck masses. So for patients with a neck mass deemed at increased risk for malignancies, clinicians should continue evaluation of patients with a cystic neck mass as determined by FNA or imaging studies until a diagnosis is obtained. You should not assume that the mass is benign. And this may necessitate an examination under anesthesia of the upper aerodigestive tract before, and I underline that, before proceeding with an open biopsy. So, for example, if you have a neck mass that is cystic in a patient that is over 40 years old, one of the possibilities, as we mentioned earlier, that it could be is a branchial cleft cyst. But I think a thing that you really need to determine convincingly before you embark on that diagnosis is that this is not a malignancy. So if you have an FNA that is equivocal or non-diagnostic, if you have an imaging study that merely shows a cystic lymph node, then I would, and these guidelines recommend performing a examination of upper aerodigestive tract under anesthesia before proceeding with an open biopsy. So that includes a direct laryngoscopy, biopsies of the base of tongue, biopsies of the tonsil area. Sometimes it requires a tonsillectomy in order to convincingly rule out or definitively rule out malignancy of the upper aerodigestive tract. If that is negative, then at that point, embark on an open biopsy. And so at that point, if the biopsy of the nexus becomes malignant, at that point, it's typically recommended that you remove the adjacent lymph nodes as well too, or do what we call a selective neck dissection in order to remove the surrounding lymph nodes while maintaining the nerves, the arteries and vessels, and the critical structures in that area. So again, if you're not able to get a diagnosis of a cystic neck mass by FNA, you should do a comprehensive examination under anesthesia of the upper aerodigestive tract before proceeding with an open biopsy. So patients presenting with a lateral neck mass and being older than 40, it's a malignant disease, again, has to be expected. So this is the typical situation. We have a cystic neck mass, and this is in level 2. So this is the sternocleidomastoid. This is the jugular vein and the carotid artery here, mandible here, spine here. So all you see is this cystic lymph node. So you can envision that a negative FNA may be misleading because of hypocellularity of the fluid. And that's why you really need to assume that it's a malignant disease until you've definitively ruled it out. So the incidence of squamous cell carcinoma in cysts is not insignificant. It's anywhere from 11 to 21%. And when you look at it, the cystic degeneration in lymph node mets from Waldeyer's ring is up to 50%. So what that says is many of the malignancies from the tonsil base of tongue may have lymph nodes that manifest themselves as a cystic lymph node. So it's really key to keep that in mind. Another point is that these cystic lymph nodes can also be thyroid malignancies. So this is misspelled, but occult thyroid carcinomas. 1 in 10 may present as a lateral cervical cyst in young adults. That's why it's recommended when you do an FNA to consider measurement of thyroglobulin from needle washout may improve the accuracy of the FNA. So for those patients that I feel have a higher risk of having a thyroid malignancy, getting that thyroglobulin washout improves your diagnostic accuracy of the FNA for a cystic neck mass. If negative by FNA and core of a cystic neck mass, as I mentioned earlier, it's key to proceed with a direct laryngoscopy with biopsy and possible tonsillectomy. If that's negative, remove the cyst, but also be prepared to do a neck dissection, as I mentioned earlier, because then you're embarking on the management of the disease process, and you want to remove all the surrounding lymph nodes as long as it's more of a selective neck dissection. So other diagnoses to consider. And so that concludes kind of the guidelines that we had previously introduced. But where do other diagnoses kind of fall into that algorithm? So this is one that you really want to identify, and these are paragangliomas. Basically, it's a carotid body tumor. So they present as painless, slowly enlarging masses. And the classic features are, on physical examination, you can move these masses horizontally, but it's fixed in a vertical direction. Additionally, radiographically, as depicted here, it splays both the internal and external carotid artery. So these, obviously, you do not want to necessarily biopsy because they tend to be very, very vascular. Also the proximity to the carotid artery. And here you can see the proximity of the carotid artery. So it sits right in the carotid body, in between the internal and external carotid artery, and it right in that general area is the hypoglossal nerve, but it's a very vascular organ. And so these you want to pick up more radiographically rather than FNA. How about salivary gland masses? So salivary gland tumors are relatively rare, 3 to 4% of all head and neck neoplasms, and a majority tend to arise in the parotid gland. When we look at them in terms of site, roughly 75% of parotid lesions are benign. And then as we start to go towards the submandibular gland, a little over 50% are benign. Sublingual lesions tend to infrequently be benign, and so that's why any lesions in these locations you want to have the appropriate threshold for perhaps dealing with a malignancy. The incidence of salivary gland masses rise at 15 and peaks at 65 to 75, whereas the malignancies tend to increase incidence after the 4th and 5th decades. So typically examination of a parotid mass, they're well defined, tend to be non-tender, freely mobile. Again, the saliva gland tends to lie right in front of your ear and lives right in this location. So it's common, pathologies tend to be located in the tail of parotid, but may present anywhere, either superficial or deep lobe. And signs that are suggestive of malignancies certainly include facial nerve paresis, pain, fixation to overlying skin, or underlying structures and associated cervical adenopathy. So these parotid masses, a key is FNA, as it was for identification of squamous cell carcinoma discussed previously. FNA really helps to determine pathology, and sensitivity and specificity are listed there. The accuracy is higher for benign than for malignant salivary gland tumors, but I typically do needle all of these because I think if you do have a malignancy, it does affect your surgical plan. You typically want to address surrounding lymph nodes as well too, based on the pathology, and that's important for preoperative counseling. In terms of fine needle aspirate, ultrasound enhances the overall accuracy. And when you proceed to remove these, it's really imperative to identify the facial nerve as detected here. And so what may seem like just an epidermal inclusion cyst along the face is not infrequently diagnosed as a parotid mass. And so it's important to, when you go to remove these, that you are prepared and have counseled the patient on identification of the, and likely identification of the facial nerve, as is seen here. So this is the upper division of the facial nerve, lower division here. This is the greater auricular nerve, and then this is the parotid mass in between the fingers there. So it's really key to identify that nerve in order to protect it. So in summary, in adults, neck masses are malignancy until proven otherwise. And really having a detailed knowledge of the anatomy and lymphatic drainage are key to working through differential diagnoses. Comprehensive head and neck exam is key, along with flexible laryngoscopy, to see all the mucosal surfaces of the upper air digestive tract. And for imaging, we talked about CT versus MR, CT being the workhorse for much of the pathologies of the head and neck, whereas ultrasound is really key for thyroid, which was covered elsewhere. We talked about the role of the FNA, certainly is integral to navigating through the differential diagnosis. Again, there are some pathologies you don't necessarily want to jump to an FNA, and that's largely the neurogenic tumors or paragangliomas. We also discussed how to manage a cystic neck mass. Again, in a patient that's over 40, you want to have index of suspicion that this is malignancy until proven otherwise. And then in general, palpable neck masses, tends to be the paragangliomas. Imaging is integral to a diagnosis. I tend to unanimously get imaging if I feel there's something palpable, like a neck mass, like a palpable neck mass, rather than jumping into a fine needle aspirate, because that'll really diagnose that paraganglioma, which would obviate the need of a fine needle aspirate. And finally, we discussed parotid masses and the importance of identifying facial nerve on any open or excisional biopsies. It's really key.